Great. Thank you very much, Celine. We're very lucky to have Dr. Eric Nelson, and I'll introduce him a little more detail later. But just to point out, he is an expert on schools and transmission in schools, and he is an experienced pediatrician who's worked in infectious disease and a member of the Emerging Pathogen Institute. Now, what I'm going to do I'm going to give you a brief overview I'm going to remind you of some of the things we covered in our last, but I'm also going to give you an update. We just had a meeting 15 days ago, and boy, things are changing, and they're changing very, very quickly. So I wanted to share that information, and I want to relate what I told you about before to schools, and then a little bit about children and how they're a little bit different, but they're very much the same. What we're going to talk about today, I'm going to give you the really the epidemiology in the background, so that I'm not going to give you answers, by the way. I am going to give you the data, and it is up to parents and students to decide on what they should do. And it's not simple, and it's not black and white. So the more you know, I think the more you will understand and be able to make rational decisions about what to do. And it's all a risk benefit. So the big problem in the United States is that we continue to expand the number of cases. And every time I show this map, it gets redder and redder. The red dots are actually the larger the dot, the more cases. And right, as you know, New York City was the major epicenter for a long time. But the last time I showed this 15 days ago, it was about 205,000. So they've only increased about a very, very little increase compared to Los Angeles, which went from 100,000 to 140,000. And that's the second most frequent, or the second highest number of cases. Remember, Seattle is where it all started, and they have stabilized in virtually very few increases in cases. It's very interesting. Now, Jacksonville is higher than Seattle. At one time, Jacksonville had 50 cases. In fact, had no cases when Seattle had its outbreak. Miami has moved up when it was in the 30,000s now to 69,000. And New Orleans is fairly stable at 20,000. Chicago has been fairly stable, as has Detroit. So the major growth areas are in the Southeast. Now let's look at the curve, the epidemic curve for the United States. And unfortunately, unlike all of Europe and many other countries, we never created a mountain. In other words, we never got the cases down to a small number. And we plateaued after shelter in place because we only kept shelter in place for a short period of time. And then in the beginning of May, everybody gave up on shelter in place. And then what happened is we had Memorial Day, and everybody decided that there was no epidemic and we would all just behave quote, normally. And as you can see, the number of cases increased to the point that we're over 60,000 cases per day in the United States. Now, the United States is 4% of the world's population. We represent 26% of all the cases, new COVID cases, and 23.5% of all deaths due to COVID-19. So, and then Florida, also a little bit on the depressing side. As you can see, the cases have, we sheltered in place, and then we reopened. We got down to a very low level, and our governor was very proud of that. And he announced to everyone that everybody could come to Florida. Well, Memorial Day, everybody did come to Florida. Everybody had a great time at the beach. And sure enough, several weeks later, we took off. And we actually created the highest number of cases in one day, 15,300. And that was just 2 days ago. And that was higher than any other state in the nation. And if Florida were a country, we would have the fourth largest number of new cases in the world. So we are really in an extreme problem. Now, I actually did an exponential, I plotted the number of cases over time from June 12th to June 15th. And it fits an exponential curve perfectly with a doubling time of cases of 2 days. This is by far the most extreme. Earlier, when we had the earlier outbreak, we actually, sorry, somehow I got my, we got a doubling time of 3 and 4 days. This is faster than we've ever had before. So it's very worrisome. Alachua County has also developed an exponential curve. We're having about 70 to 80 cases per day in Alachua County. Now, Harvard Global Health Institute recently created a map of every county in the United States. And they defined what should go on, what the dangers of each county were by the prevalence of cases per 100,000. If you have over 25 cases per 100,000, that indicates unchecked community spread, and they recommend stay-at-home orders are the only way to control the epidemic. If a state is orange or a county is orange, that's 10 to 24 per 100,000, then you probably will have to stay at home, or you've got to escalate your community, your case finding, and really be aggressive. This was as of June 29th. There were 2 states who were in red. There were 14 in orange. And then 1 to 9, you can open things up a little bit. And then green is less than 1. And you can see at that time, Florida and Arizona were red states. Well, now that's been updated. And here's the map of the United States now. And you can see all this red, and it's all in the southeast and also a little bit in the southwest. And if you look over here, it's a little faint, but Florida leads the nation as far as the prevalence of infection in the United States. It's ahead of Arizona. It's 50, on average 50 per 100,000, followed by Arizona, Louisiana, South Carolina, Texas, Alabama, Georgia, Tennessee, and Mississippi. All of the SEC schools, we're all champions in creating infections. And on the left here are the low states. Vermont only has 1.1 cases per 100,000, and New York now has 3.4 per 100,000. So they went from the epicenter to very quiet. Connecticut is the same. Really, basically the East Coast now is 3 to 5 per 100,000. Now here's the map of Florida as of today. And you can see almost every single county is red, and there are a few that's orange. And this has changed in the last 8 days. It's gone many more red. And you see that now the Miami area is 98.4 per 100,000. Fort Lauderdale is 70 per 100,000. Collier County is 51.6. Orlando, where they opened Disney World, is 46 per 100,000. The Hillsborough, Tampa area, 50 per 100,000. Alachua County, we're red, we're at 28.5 per 100,000. And Jacksonville is way up there at 57.9 per 100,000. So these are all red. The recommendation by the experts is we should be sheltering in place. Now, how are we going to control this infection other than shelter in place? And I did review these in the last presentation. There are 5 things that need to be done. We need to all wear face masks. We need to avoid closed spaces. We need to physically distance. We need to avoid large crowds. And we need to be careful on hand hygiene. Now, what about wearing face masks? The last time I showed you a study that showed incontrovertible evidence that face masks protect and prevent you from spreading your micro droplets to others. And we talk about the R sub 0, which is the number of cases when one person is infected, how many people do they on average infect? With this virus, the average is one infected person infects 2 to 2.7 individuals. And in situations of close contact, a 10% chance of infecting, and 80 to 85% of cases are in close contact in family clusters. If we were to wear masks, the R sub 0 would go to below 1. And Goldman Sachs has estimated that if we increase mask use by 15%, we could reduce the economic losses by $1 trillion. So this makes sense financially as well as health-wise. And I went through this before, but the point is there are many ways that you can make your own masks. You can buy masks from Korea, China, from the Amazon, or even Publix has masks. So they're very easy to get and very available at this point. And my wife, Kathy, wears a face shield, which is also very effective. Now in the hospital, we need N95s. Those are very fine filter, and in general, we do not need these in the public. Now, why are we wearing masks? Well, I wear a mask to protect you, and you wear a mask to protect me. So this is a community spirit. And so when someone's not wearing a mask, they're telling you, I don't care whether I infect you or not. Is that a good message? So one of the questions when we're talking about schools, can we convince children and young adults to wear masks? And the CDC recommends masks for everyone in the school. The CDC points out that below age 2, masks should not be worn. Now, the second is avoid closed spaces. And we talked about this before. Small rooms, closed spaces are very risky. And that is, unfortunately, a lot of the school rooms are small. So they would be on the danger area, small space, probably low airflow. Larger rooms are better, and large rooms are outdoors is the best. So a closed environment is 18.7 times more risky, a higher likelihood of getting infection than if you're in the open air. So open air is preferred whenever possible. And then the airflow within the room is very, very important. And the air should be coming in from outside. Ideal is 6 to 10 air changes per hour. The average building, unfortunately, is only 3 per hour. And the CDC does recommend that the ventilation be properly operating, and the higher the circulation, the better. And whenever possible, bring outside air in and open windows. Now, that's not realistic, unfortunately, in Florida because it would be too hot. I should point out that restaurants are extremely dangerous, as are bars. And that's where we've seen a lot of the spread is in those closed spaces, very dangerous. Now, it turns out the duration of close contact is very important. And if you can avoid close contact for under 10 minutes, you're unlikely to pick up infection from somebody. But unfortunately, when we're talking about school, they're going to be together for 8 hours a day. So this time component is not going to be respected. So what are the CDC recommendations for schools regarding space? Space seating and desks at least 6 feet apart. Turn desks to face the same direction rather than facing each other. Or have students sit in only one side of tables spaced apart. Create distance between children on school buses when possible. Seat one child per row and leave the windows open. Install physical barriers such as sneeze guards, partitions, particularly in areas it is difficult for individuals to remain at least 6 feet apart. And provide physical guides like tape on the floor and make the hallways one-way directions so people aren't facing each other. Now, third is maintaining 6 foot physical distance. And the reason we do this is because when you cough, when you speak, when you sneeze, you do release droplets from your mouth. And in general, the droplets will drop at about 1.5 meters and will usually not reach beyond 2 meters, except if you sneeze. Now, the problem is these drops are a continuum in size. And if you're just breathing, you will also release some smaller droplets, less than 10 microns. Those are what we call the aerosols. When you're in a small room for a prolonged period of time, it's highly likely that aerosol becomes a problem. And that is one of the concerns with schools. Even with masks, aerosol, if there's an aerosol, that will not work. Now, can we in schools maintain 6-foot distancing? That's a major question and is very difficult to do. We want to avoid crowds. So classes need to be small. They should be ideally less than 10. Do we have sufficient numbers of teachers in classrooms to achieve that goal? So what does the CDC recommend as far as large gatherings? Close all communal spaces, shared spaces. If you have to use them, playground equipment, etc., they should be staggered use and clean and disinfect between uses. Add physical barriers. Everyone should bring their own meals if feasible. And if you have to cafeteria, then individual plated meals are brought to the classroom, not in a communal dining hall. Virtual group gatherings rather than real group gatherings are preferred. And if you have a gathering, it should be 6-foot distancing. One thing that I think is very effective and has great potential is creating bubbles or learning teams. That is a group of students that stay together the entire day and actually socialize afterwards. They do not have to physically distance. When they're together, they do not have to wear masks. And this also could work in the universities. And I know the athletic teams are actually doing that. In other words, within the team, 4 or 5 people stay together and they are one entity and they don't have to mask when they're together, but when they're outside, they mask. When they come in contact with other groups, they mask. That way, if one person gets infected, you only knock out a small group and you know exactly who to contact trace. And finally, wash hands. And you want to sing happy birthday twice when you're washing with soap. And a big issue is also you want to clean surfaces in public spaces. And the CDC recommends that that be daily and if possible between uses. So now what about children? What do we know about the susceptibility? Well, first of all, they only represent, of all the cases, 1 to 2% of the total cases. And when you look at if adult 100% is the infection rate of adults, they are 1/4 to 1/3 as susceptible. So 44 to 25% range. So they have a lower likelihood of infection. And if they're less than 10, they have the lowest susceptibility. Severity of illness, mortality is very rare in children with the exception of those with underlying diseases. 80% of those who have died have had underlying diseases. And there is a syndrome, it's really a post-infectious syndrome called multisystem inflammatory syndrome. It's rare, it usually is not fatal, but it can be very serious. Now, what do we know about transmission of children to adults? 5 to 10% of household cases, the child is the index case. In other words, they were the first one infected and they spread it to the family. So children rarely are the ones responsible for spreading. And transmission in schools is rare except in high schools so far. And usually in schools, it's adult to adult. So teachers are transmitted to each other rather than children to teachers or children to children. Should children wear masks? Everybody agrees that they should when they're over age 2, and probably about age 4, they're able to do it reliably. Now, the ACE2 receptors increase with age, and those with less than 10 have a low number of receptors. And here, now what's the ACE2 receptor? In one of my first talks, I pointed out that the virus actually binds to receptors on cells, the ACE2 receptors. When it binds to these through these outer knobs or S proteins, the virus is internalized. So if you have fewer ACE2 receptors, you can't bind to the host cells, and you're less likely to be able to internalize them. And here is the number on respiratory cells for those under 10 versus those that are 18 to 24. And you can see there's a very significant lower number in those under age 10. Now, what about the teachers? And I think this example tells it all. Kimberly Lopez Bird was 61, and she died in Arizona on June 26th. with after less than 2 weeks hospitalization. She worked at this school in Arizona for 38 years. And she was working online teaching, but she was in a classroom with 2 other teachers, and one of them had the virus, and they were wearing masks, they were socially distancing, but she still got it and she died. So the big problem is it's estimated 25% of teachers either are over the age of 50 or have underlying illnesses, and therefore are an increased risk for serious disease. And we know that as you get older, the mortality goes up. If you're 50 to 59, it's about 2%. If it's 60 to 69, it's 4%. If you're 70 to 79, it's 8%. And if you're 80 or over, it's anywhere from 16 to 25%. So Alachua School, apparently you have to choose what you want: traditional school, where you go back fully physically; the digital academy, which sounds very robust, which is really distance learning, or which is synchronous. That is, the classes are held virtual, but everybody is in the class at the same time. And then they also have the Alachua e-School, which is asynchronous. In other words, you can watch the videos and do the exercises anytime. And then finally, University of Florida is planning to open up. And their policies, they're going to test everyone before they start. They're going to do monitoring by batch testing. That is, they'll pool samples for 8 individuals and do a PCR. If that's negative, everybody in that pool is negative. If it's positive, then they have to test all 8. There will be universal masking in all public spaces and isolation of positive cases, quarantine of contacts for 14 days. There will be small in-person classes. Exactly how small, I couldn't identify, but mostly will be virtual classes. And the dorms, they're decreasing the number of students in a dorm to 2, and no triple dorms anymore. So what about the testing? Well, PCR is the only test to assess infection. It's very expensive. It is time consuming. And it's after the first test, ideally to prevent the infection, you would have to do this every 2 weeks. Is there another way? Could temperature checks be effective? And I've discussed before, there is an electronic thermometer that could be purchased where the student could check their temperature twice per day and then go through, and it actually communicates with your smartphone. And then plus the temperature, you go through a series of symptoms. If you're afebrile and you have none of those symptoms, you get a green light, and you can show that at the door of the school to prove that you are not infectious. If you have symptoms or you have fever, then you can't go to school and you have to stay home. Now, I have a video of Tony Fauci talking about schools.
Because obviously, if you have massive outbreaks where you have an exponential elevation of a curve of new infections in a particular area, that you really don't want to have the kids go to school there. But we really need to be much more flexible in what we can do to get the children back to school, because just as a reflex reaction of closing the schools sometimes has some downstream effects that make things even worse for you with regard to home care, families, daycare, things like that. So a fundamental principle is within the realm of some prudent evaluation of the safety to the children and the impact on the community. We should try as best as possible to get the kids back to school. In certain circumstances where you get them back, but there's still viral dynamics in the community, there are a lot of creative ways that superintendents of schools are thinking about seriously about how you can mitigate the possibility of there being children being the vehicle of spread. Alternating days of classes, morning versus afternoon, the wearing of masks for children who are old enough to be able to understand what it means to have a mask, having capabilities of online for children who have underlying conditions that might put them at risk, protecting the teachers, making sure that they have the capability of not being part of an issue of spreading infections, so that you just do things in the school to mitigate it. But the principle should be, how can we prudently with sensitivity to the safety of the kids, get the children back to school. A little bit different with the universities. You know, there are some creative ways that some of the university presidents are doing, such as, you know, test everybody once before they go back so you know what the baseline is, and then do intermittent screening to determine, is there anything under the radar screen? Maybe have a separate dorm so that when a person does get infected, they could go there if they're otherwise healthy and be sequestered from the rest of the campus or the rest of the university. There are a lot of things that are going on right now. I believe in a very thoughtful way how we can get the educational system somewhat back to normal. Bottom line also, Howard, to just get this in before we move on to the sports thing,
Right.
is the issue of making sure that you make your judgment depending, particularly with the elementary schools, the lower education schools, not the higher education of colleges, that is going to depend on the level of viral activity in the location where you're at. So we make sure we don't make any unidimensional statements like, in the United States, we should do this. Because there are going to be some counties, some maybe even some regions where the infection is so low, there's absolutely no problem whatsoever with just making no changes in schools. And there may be other areas of the country where the viral dynamics is so intense that you really got to be really, really careful when you make that decision. So we got to be making sure we don't make blanket statements for the country and talk in terms of the activity in different regions of the country.
So now I wanted to introduce Eric Nelson, and I already mentioned that he is a member of the Emerging Pathogen Institute and an assistant professor of pediatrics at the University of Florida. And he got his medical degree at Tufts University, a pediatric residency at Stanford University, and a pediatric global health fellowship at Stanford. And he has been studying pediatric diarrhea, including cholera, but now is focusing on the role children play in the community transmission of COVID-19. So I will end here and close my share. And Eric, welcome.
Okay, great. And then Sarah McCune's on the line as well. I saw her picture a minute ago. And she and I are colleagues in a study here at the University of Florida. And I'm just going to introduce her as well. Sarah, can you hear us out there?
Yep, I'm here.
Okay. Yeah. So Sarah and I have very complementary skill sets. I'm a pediatrician. I have a PhD in microbiology. I have a master's degree in environmental microbiology. And both Sarah and I have worked internationally on a whole bunch of different topic areas, including outbreak response. My domain is more cholera. She has worked on Ebola. But Sarah has a MPH from Emory University in global health. She has a PhD in interdisciplinary ecology from the University of Florida. She did her postdoc here at the University of Florida, and both of us are in the Department of Environmental and Global Health in the College of Public Health, and we both reside at EPI as well. Sarah, anything you want to add on your background there?
No, only that I'm by training a social scientist. So I look at the intersection of social stratifications like gender, race, identity, and how those affect health outcomes. So the health outcome is less what drives my research than understanding what puts people, what are the social determinants of risk, and what makes people vulnerable for these infectious diseases as well as other health outcomes.
So thank you, Sarah. Yeah, so it's really fun. I'm more of a bench scientist. I work clinically, and it's just really fun to work with Sarah, who have very different backgrounds. And you can clearly see by the presentation that was just done, as well as your own experiences, is that COVID-19 really sits at the interface between behavior and biology, mechanistic infectious disease biology. And so you can't isolate one from the other because this outbreak is right at the interface between the two. Now, I don't know how much time we have, but I have 2 pieces of paper with some comments I want to make, and then we can open things up for questions. Because I think that I looked at the questions at the bottom of the slide deck, and as you know, things are moving really quickly. and I think it's really important to have some principles and big picture understanding as things change from day to day. And so your compass is well set. And so if something deviates from day to day, you can keep going. I don't know if you want to go north or wherever you want to go in a given direction. So both Sarah and I are parents. She has 3 children. I have a 8-year-old daughter who's about to turn 9. And I think that this conversation is really personal as well as professional. And we have to bring the two to the table to work together on this. And I was making a little list of how I've been personally affected by COVID so far. I have a colleague in Bangladesh. His mother died of COVID a couple of weeks ago. My lead engineer in Hyderabad, his father and his uncle died of COVID in Kolkata a couple of weeks ago. I have 2 brothers-in-law that have COVID. One is in New York, one is in Los Angeles. I have 4 staff in Haiti that have COVID. My wife's coworker is in the hospital with COVID. And then my daughter, myself, my wife have had unexpected COVID exposures. It's almost on a weekly basis right now. So I'm sure you've all had similar stories, but it is so much so here and real and getting worse. And I think that a lot of people are stressed and struggling with this question about schools because we're forced into a dichotomous situation of thinking about physical health and safety of our students, our children, our teachers, our administrators, the staff working at the schools, versus education and psychological health. And that's just a lose-lose dichotomy, and it's unfair, and everyone should be mad. I think sometimes you have to acknowledge that to have a healthy discussion, because the real problem is that we're in this situation. And there's not going to be a right decision with this dichotomy. We're going to have to compromise and figure out a way to get through things the best we can. And I've spent the last 15 years using cholera outbreaks as a model system to think about how we can better respond to outbreaks in general for whatever disease. I've worked historically in the poorest places on the planet, and typically in areas with conflict zones that are both violent, have incredible inequity, a lot of racism, a lot of poverty, a lot of instability. And it's been interesting over the years, communities get through this. There is another side, and the timeline for that can be very long. I came here to the University of Florida because I largely made a commitment to Haiti in 2010 when cholera came in there, that I would go back to Haiti and solve some of the fundamental underlying health challenges I saw for children, or at least try to solve those. And to do that in the context of cholera. And so cholera started in 2010 in Haiti. I came to UF in 2016. The last case of cholera in Haiti was in January of 2019. So that's a 9-year journey that outbreak took. So I think of this problem that we're facing as a multi-year journey. And even though cholera was endemic for more than 5 years in Haiti, it was eventually eliminated. So there is another side. You just have to think, what's the timeline of that? So that's my positive bit. A couple clinical things on the part about COVID in children. We think about COVID as really a respiratory illness in adults, but I do think that the country and maybe the callers today, we need to pivot a bit in pediatrics to think about COVID as an inflammatory disease, and including what we call a vasculitis, because children do manifest the pulmonary components, but there's also the small vessels get infected. There's also inflammation. And whenever there are small tortuous vessels in the body, that can cause lots of problems. And so we see in both kids and adults, we see neurologic problems, we see cardiac problems, we see COVID toes, we see painful skin, in older patients that are diabetic, we see kidneys having issues, which is because they have small tortuous vessels there. So we have to think about the physiology being broader than just pulmonary, which makes it a very difficult disease clinically to manage. The other thing is that when kids do get infected, their viral loads are roughly equivalent to adults. And the body of literature that we have on children is in the context of this outbreak, which in the US largely began kind of February or March. And so what we know about COVID in kids epidemiologically is based on times in which schools have been closed. And when schools are closed, the people that are leaving the household more often are the adults and not the kids. And so the adults go out and bring the disease into the household. Now, that is sort of the opposite of what we normally think of for respiratory illnesses, including coronaviruses, where the kids go to school or daycare or whatever it may be, and they just bring home every year boatloads of viruses. And you know, on day one, when your kid develops a small fever and a cough, everyone in the household is going to have it in like 3 or 4 days. And I think that some of our understanding of COVID in kids is an artifact of just schools being shut down and their social contacts being shut down through the March, April, May, June-ish period. I think we'll have another round of epidemiologic studies since we opened things up last month that might tell a slightly different story. The other thing is that health systems that have universal healthcare have been able to deliver clinical studies a lot faster and more robustly than the US system. And so a lot of our clinical studies on pediatrics have come from European countries, China, South Korea, Singapore, and those are much different domains. And a lot of these studies have taken place where their level of disease was a lot less than our level of disease. And so when we think about control and mitigation, it really depends on how much disease you have around. And if you have a ton of disease and you're leveraging a literature that's from a place with a little bit of disease, you might be off base a bit. And then the other thing is that most of what we know is from Northern Hemisphere countries, mostly developed countries, and also during a period in which the flu season was just ending and the non-flu season was starting. And in pediatrics, when I work inpatient, about half of our cases, maybe a third of our cases in the wintertime of a respiratory illness are co-infections. So you might have RSV and a traditional coronavirus, or flu and RSV, or metapneumovirus and RSV. And the co-infections tend to tip kids into getting into lots of trouble. And so we're going to go into that zone in about a month and a half, and we don't have a literature on what co-infection is going to do. And so Sarah and I are leading a study at the PK Young School, and then we just submitted a grant about 20 minutes ago on a prospective study in the pediatric ED, starting to look at these questions of co-infection. And I'm just going to keep racing because I'm almost done with my second piece of paper. I am most definitely not an expert on this field. And it's fun because no one really is. And so I sent a link into the chat box to a Mass General guideline that is outstanding. It's probably the best one I've seen. Whatever I say, take it with a grain of salt and reference that reference I gave you and read into it, because that'll be a more definitive source than what I have to share with you. So going forward in terms of, the other thing is that I'm definitely not a lot of things. I'm not an epidemiologist. I'm not a virologist. And I'm not an infectious disease clinical subspecialist. And as we go forward in this discussion today, I want to frame things in a mindset that is really important. I don't think that we should approach schools as a what if the school will be infected. I think we should approach it as when the school is infected. I would say it's almost 100% probability that every school that opens will have a COVID outbreak. And for sure in the first year, but I'd almost say within the first month, there will be a COVID outbreak. And so when we think about strategies, we have to have a strategy such that you can open a school, you can have an outbreak, you can mitigate it without having to shut the school down. If you can't do that, there's no point in opening the school at all. And so to kind of reiterate some things that were said before, pods are essential. My daughter is at a summer camp right now. They're in pods of 8, and we actually put her in this camp as kind of a self-experiment to see what it would take to get a kid in the school. I'll leave the school and the system that she's at right now not named, but basically she's been in a pod of 8 students and a teacher. And this is a private school, which speaks to aspects of inequity and resources. They temperature check, hand wash in, they wear a mask all day. When they're outside, they take their masks off, and no pods interact. Now, another pod did have an asymptomatic case, and they were able to mitigate that situation and keep the school open. And it was a really good example of kind of what was being taught early in the talk. So point A is, I think pods are required. Things called odds ratios. Basically, you can drop rates of infection by around 80 to 90% by wearing a mask. Distance by about 80%. Face shields as well drop this risk. And these odds ratios are not necessarily additive, but kind of in a linear fashion, but they do help each other out. So if you do a couple things together, it really starts to drop these numbers down. Air ventilation was mentioned. As we all know, like the portables that you might have attended or my daughter has attended don't have great systems for ventilation. Hand sanitizers. And then this idea of aerosolized particles versus these droplets is really important. And we have to think about, if you have someone coughing, not only are they going to drop the droplets close to you, but they're going to create a cloud of COVID. And that's been pretty well documented now. So just, again, for maneuvers to do, pods, PPE, and I put mask, distance, and you know, clinically we use face shields. I don't think kids need face shields. Sanitizing and air ventilation are kind of 4 domains that are really important. So those are all the pieces I had to make. Sarah, I'll turn it over to you.
I think I'm unmuted now. Thanks, Eric. I didn't make extensive notes. Many of the questions that we got ahead of time were fairly clinical or teaching oriented, and I bridged that gap in a sort of meso space around the social science. But I will add a couple comments that I just jotted down in listening to Eric. I think to go back, I've spoken to a number of people on school boards, both in the state of Florida and other places where I have family and friends connected. And I think one of the most important things that we really get our head around is Eric's opening statement about that we don't have a good choice, right? That we're really weighing 2 not great options. And you can prioritize the epidemiological, the clinical space, or you can prioritize the educational and psychosocial, but you can't really have both. And so what we're talking about is trade-offs. And I think that one of the things that we have to think about as we do that is the inequity in the system and how those choices will exacerbate inequalities that exist, both health inequalities as well as other inequalities. And so that's the space that I work in, and that's sort of the lens through which I see these issues. We want to mitigate the health outcomes, the negative health outcomes, but what if that best action to lower the risk of COVID exacerbates not just domestic violence, but food insecurity and depression and OCD. And in our pilot study that Eric and other colleagues and I have operationalized in Gainesville, we see that there are rising rates of indicators of stress and depression and OCD in kids already. And that was in April. That was at baseline, 1 month after lockdown. So we know that the very same things that protect kids from COVID may exacerbate other health outcomes. So you're not saying, why don't we do the right thing? Why don't we protect our kids? Everybody's trying to do that and trying to figure out, from what are we protecting our kids? And when we do that, what are we exacerbating their risk of? So it's really about trade-offs. It's a very complex space. And I don't envy, I don't know if anybody on the call is in that space, but those who are working in the educational system and trying to make these decisions for not just Alachua County, but other places around the country, it's an unenviable position because they're not good options. And that brings me to the second point, is that all of this takes resources, right? I mean, if resources were unlimited and we could put money and time and energy into this, I really, really appreciated the talk, because there are creative solutions and people are coming up with them, but they take time to plan out, they take political will, and then they take resources. And so I think as much as possible, the ways that we as researchers, but also individuals, can really be advocates for saying we have to push the science to put the evidence base in the hands of people who are making policies, so that we have, for example, time to make a plan. I know the Alachua County School Board was voting at 4 o'clock on when they were going to bring students back. You know, are we really going to bring students back in whatever form that looks like on August 10th? Or do we need more time in order to do it safely? And so these are the types of questions I think as community members we all have to be advocates for. Let's see. The other thing is thinking about the work that I've done, whether it was in the context of HIV or Ebola. Again, like Eric, most of my work has been international and not just on infectious diseases. I work a lot on issues of food security and nutrition. But when you think about this epidemic and this as it is in our own community, one of the things we have to bear in mind is that this really is a new virus. And so one of the things I hear from very smart, educated people as we go through this process is, you know, nobody knows what's going on. Well, people really are learning at a rate that we haven't seen many times in history. I mean, the human experience of learning is happening at exponential rates right now. And we know so much more today than we did 3 months ago. And we will know so much more 3 months from now than we do today. But what that means is that the policy has to change. We have to be nimble. We have to get comfortable with the uncertainty of the future. And then we have to get comfortable with the fact that the plan is going to change. And that's really hard for people to do. It's really hard for adults to do. It's extremely hard for kids to do, because when you disrupt that predictability, it causes them all sorts of insecurity. And not to mention the feedback loop. When parents and teachers are stressed out and feeling whatever the manifestation of that uncertainty is, the kids pick up on that feedback loop and it just exacerbates. So getting comfortable with uncertainty, I think, is a huge piece of this learning curve for all of us. And some of the ways I think we've seen that manifest is the masks. I mean, you go back and initially language was, oh, it's not airborne, you know, it's not transmitted that way. Oh, now it is, but everybody doesn't need to wear a mask. To now, I mean, the evidence is indisputable. Everybody should be wearing a mask. I read a study coming out of Japan, and really the attribution to the rates there are the near ubiquitous use of masks, right? That's one of the major things going on with the transmission there. So again, Alachua County School Board was voting today on mask ordinance. Are they going to mandate it or not? Many states are, even some are reversing course. But the other place I see that is around ideas of herd immunity, that we've really moved away, thankfully, from this expectation that if once people get it, that they're going to be protected. And I think this is something that's as schools open up, we're going to have to, as public health professionals, get better about the messaging. And, you know, messaging is hard when the message changes, but we've got to get good at conveying to people, as the science changes, what is it leaning towards now? What is it looking like? And there's still a lot of, I don't mean to say that this is definitive, but as Eric alluded to, most of my work is in sub-Saharan Africa, and there's all sorts of research happening there, looking at, trying to look at prevalence rates and also looking at the presence of antibodies and doing the math and doing the modeling to say, what does that mean about transmission and how much is happening? And most indications are that we're not going to be moving towards a state of herd immunity. So we do have to get to a point where this is all in response to Eric's sort of allusion to the fact that we will move through this, no doubt. We will move through this and we'll come out the other side. When and how long, I think we have to take a long game run on this. I think we have to think about it being a new normal for a while. But I think the fact that it's a new virus, we're still figuring it out. And the idea that there's possibilities that this becomes endemic, that it's something that is in society in a way that is not just eradicable or you vaccinate it out or it's simply gone. We have to think about what that means. And that means that schools need to open, right? And this is something I've had to come to in my own space terms with, because it's not a dichotomy of they're closed or they're open. And yet that's how it's discussed. The question is, of course they need to open, but how do we do it safely? So what does an open school look like? And I really loved the clip from Fauci, because that's exactly right. It depends. The safest, most honest, data-driven answer is almost always, it depends, right? Because you need all of those other covariates in your understanding. What is the transmission rate? Who's vulnerable? All of those things will go into when schools open and how to do it safely. Those are my thoughts based on your comments, Eric's, and the presentation before, but I'm happy to take questions.
Okay, wow. I just want to say thank you to our speakers. That was some very educational and informative and powerful information that we just got. So thank you to everyone who just spoke. I'm going to start sharing my screen, which has some questions on it, and we can just kind of dive into that together, and we'll see how many we get through. All right, so our first question, I'm gonna hide this, is what are the current, this will probably go to Dr. Southwick, but what are the current availability of hospital beds in the community now, and how can we expect when college students, faculty, and other staff return? Can we expect reduced access to medical care and hospitalization?
Yeah, I'm afraid the prediction is that we do have capacity, but what we have to do is we have to drop back our elective procedures, a lot of things that are not emergent, and to manage the beds. We're almost 900 bed hospital, so we do have a lot of flexibility, and we have a lot of ventilators, and we have a lot of physicians, and we have a very three-tiered emergency plan, and we're still on the tier 1. So I think we can manage it. We'd love to see the epidemic slow down, and because it seems to be, as I showed you in that curve, it's not flattening at all, and that means we've got to do something else besides just take on all these cases. And that when the college comes, it probably will cause some upswing, but we hope with the approach that Dr. Fauci, pretty much what Dr. Fauci described and I described is what the university is going to do. And hopefully we can keep it contained. I think that's possible. So it may not reflect in a lot of admissions, but there will be some. And that will mean access will be a little bit more difficult.
So the next question is, and I think Dr. Southwick talked about this at the beginning of his talk, but is it safe to send our kids to school given the current rise of COVID-19 cases? And that question's already been answered, but I'll let someone answer it again.
I'd like Eric to weigh in on that. And Sarah, both of you can weigh in.
Yeah, I just like Sarah's answer. It depends.
Yeah.
If you have pods, if you have a plan, when the school gets infected, to mitigate that and keep the school open and keep people, including the teachers, safe, I think it can go forward. The other question that we have to get used to is using the word safe. It's a relative word. Everything is not as safe as it was pre-COVID. So you have to use that word in a relative sense.
Yeah, to that point, Eric, another thing we're finding is that in the hospital, when people are working in the hospital, they're wearing their masks, they're wearing their face shields. There have been very few cases. it's turning out that the people, when they're outside of the hospital, get infected. And I think that may be similar in the schools. If families are going out, they're going to get infected there, probably almost as much as in the school. So is it going to really make it less safe to be in school and learn as to be out in the community? I don't have the answer to that, but certainly we can tell you in a lot of industries, it's been found that people are safer at work than they are at home or outside.
And on those, on that level, I think what's emerging from both literature and anecdotal experience is that break rooms, lunch rooms, are a great venue for exchange of germs. So that I know there's been outbreaks in settings here in Gainesville through lunchrooms. I have a colleague in, in South Africa. They were having outbreaks amongst their staff, and as soon as they shut down their break room, those stopped. I think the same thing in schools. I think the lunchrooms, the break rooms for teachers will probably have to be closed because that might be even more dangerous than being in the class.
Right.
So the next question is, will the schools have band? I think that was partially answered when Dr. Southwick was talking about, college football students, but I guess we could talk briefly about extracurricular activities and how those might be affected.
Well, Eric gave me that MGH review, and actually bands are not particularly dangerous. I mean,
I think it's relative. They're not as dangerous as singing. Yeah. And
no,
my daughter spends most of her day singing. So she's gonna be really upset when she reads that document.
Yeah.
This one is specifically about children's ministries in churches. And does anyone want to speak to protecting children in children's ministries?
I think it's all the same procedures. It's all the same. And Eric, I think what Eric said, and I think that's what a lot of the child ministries, 8 kids. You have limited numbers. You have to have lots of classes with small numbers of kids. So if something happens to one, you don't wipe out the whole school. I think that's sort of the key.
Which gets to my point about resources. I mean, it's human resources. It's how do you take a class that typically has 24 kids in it and break it up to 3 pods? You could theoretically have 1 instructor and 3 assistants, right? Those could be younger, less vulnerable, no underlying condition, people leading sort of academic assignments once they're made by a teacher who's in a face shield and remaining 6 feet apart. And then especially thinking about K through 12 kids, where you've got then assistants who are lower risk going into these pods of 8 to work, more one-on-one. But that's a lot of resources for a public school system and a lot of organization to get it up and running, and physical space. If everybody opts in or is mandated to be back, which is varying by state, that's a lot of space. One of the things that both UF and I know the public schools are looking at is the use of outdoor space. We're in Florida and it's miserable. I'm actually not. I'm in Michigan right now, so don't damn me that. But the heat of Florida makes it horrible to think about right now, but tenable for us in a way that many states it's not throughout the year, is to use outdoor space for teaching. I teach 2 graduate courses in the fall, and both of them will be outdoors for the components that are in person. So I think, that the human resources as well as the physical resources, including space, are the commodities that become limiting factors in our ability to do these things safely.
Okay, and I think this might be our last question because we're past 6, but it's with summer camps closing because of children and counselors getting sick. What are your thoughts about pediatric spikes during schools? So what can we take from what we've seen during summer school, and how can we apply that to school going forward?
I go back to the pod topic, but I also think that we have to think about the physiology of a young child, a middle school child, and a high school child being very different. And so if some of the preliminary science is right, that these kids really do have, the young kids have less ACE2 receptors and have less chance of viral particles binding their lung tissue. That does give them a little bit of an edge. There's some really good studies amongst high school students that just had basically wildfire outbreaks. And so that means you can't have the same policy across all K to 12. And that's going to be even harder for people to adjust to. So I think lessons learned over the summer with with summer camps should be applied to the fall. And we really need to get this sorted before the flu season starts. Oh, and the other thing is get your flu shot.
Yeah.
Absolutely.
I think another piece is just the level of asymptomatic cases in kids being so high that really problematizes. There has to be some sort of surveillance system, because otherwise they just become a portal for the community. And until that's better known and quantified, it has to be seen as a risk factor.
Okay, I think it's 6:02, so that'll have to do for today, but we will continue to have conversations like these about COVID and how to keep our communities safe. And so thank you everyone for joining us, and thank you to our speakers for talking. Any last words from Dr. Southwick?
Well, we realized this topic was so big that we've decided the next meeting will be in 2 weeks, 2 weeks from today. I think that's the 29th, and we are hopefully going to have the superintendent of schools be present at that, as well as possibly some teachers. So we'll carry on. I think there are a lot of issues that we couldn't raise, the questions left over, and the issue of the teachers as well. So I think there's a lot more to this, and it bears more discussion. We'd like the second one, since we've got the background now, maybe we can have more in the way of interaction